first question. Before Nuno asks the question, let's transmit to you one question, since you were the first one to give a talk, that we received from the online audience. Has anyone ever studied the overlap between ADHD and ME? And do both shared acquired neuroinflammation as a starting point or similar risk factors?
Yeah, good question. So the question is ADHD and ME. Yeah, my understanding is that there's a overrepresentation of ADHD in patients that have been diagnosed with ME. And whether or not it's driven by neuroinflammation, I don't think that ADHD is thought to be largely driven by neuroinflammation, but it is at least largely the effects are within that same circuitry that I was describing. So the anterior mid-cingulate and superior parietal cortex circuitry is the exact circuitry that's disrupted in ADHD that gets normalized by Ritalin during development, for example.
Thank you. Nuno.
Hi. No, great talk. My question is to Resia, and I just wanted to ask you about this alpha-2 antiplasmin. Just connecting with yesterday's decode ME. I was just wondering if actually this protein could be a candidate for some kind of genetic association that will increase. Have you done something about genetic associations with the protein? Or...
That's a very interesting question. We have not ourselves looked at the genetic component, but it will be really interesting, I think, if the decode, if someone working on that samples, if they could actually look at that, because that would give us some indication if there's some genetic reason why alpha-2 antiplasmin is upregulated. Because we haven't come to any conclusion why it's upregulated. Obviously, it's produced also in the liver, and it would be really interesting to. But we also found some other molecules, other proteins that's also blocking the process of breakdown, and we think it's specifically interesting that it is probably associated with spike, but we haven't done the genetics. It would be very interesting.
Let me ask now a question to Dr. Klimas. That was something that we received also from online participants. Why did some patients do not respond to the antibody therapy, to the CPA, VRT therapy that you mentioned? And why does influenza viruses sometimes do diabetes type syndromes and sometimes ME/CFS?
Well, the first question is easier for me to answer since we're doing the study. We'll know. But we don't think that everybody with long COVID necessarily has a reservoir of antigen. So we just don't have an easy way to measure the entire reservoir since it's hiding in solid tissue. So I think we'll hope to find a subgroup that should have a lot less immunologic antigenic drive if we could remove that much antigen. I also don't know if the dose that we're using is the right dose. We're using the dose that was approved as a repurposed drug. It was the IND requirement. So we're using a single dose. The drug has a 90-day half-life, but so it'll last for a long time, but we don't know if it's enough to mop up sufficient antigen to really start clearing the reservoir. So we'll find out with a study like this where we powered it to pick up a relatively small, 25% or greater subgroup. And the influenza diabetes question, I honestly don't know the answer to that question, so I'll pass.
Thank you. We have a question there.
My name is João Vink. I'm a clinician. I'm basically pulmonologist. And when I come tomorrow to my clinic, I would like to ask Dr. Klimas about what would you recommend for screening for viral reactivation and for lymphocyte subpopulation. So what would you say to me as a clinician I should order tomorrow for my new patient that comes to my office? So how would I, with all that info, amazing information that you gave us, how can we do that on our day-to-day basis? Thank you.
Yes, I appreciate the question. So in our clinic, we measure the serology. We use the EBV panel, which includes early antigen, BCA, EDNA, IgG, and then IgM to VCA. So that's for EBV antibody tests to give you a pattern of old versus reactivated versus new infection. HHV6, I don't know how widely it's available. It is available. The HHV6 titer of 1 to 160 or greater was what predicted response in Dr. Montoya's VALSITE study. So I would imagine that's clinically relevant if it's a high titer. You can PCR, but again, like I said, do that more than once. I wouldn't just do it as a single screening test. The other viruses are harder to follow and less likely to be found, like CMV and the Coxsackie B virus. You can look at the serology, but that doesn't tell you if it's reactivated. Coxsackie B is the virus, yeah.
I think there is a follow-up.
Yeah, just about the immune cells. So what would you recommend about lymphocyte subpopulations? What should we ask for?
So I guess my clinic's a little special because it's an immunology clinic and I have a high complexity laboratory that I can refer to. So I get flow cytometry panel that looks at more than CD4, CD8 NK cell number. What's broken here is NK cell function. So the NK cell number could be low, but NK cell function is low. And then in the flow panel, it's not too helpful unless you start adding some activation markers or senescence markers. Now the question is, what would you do with that clinical information, and should you run it if you don't have a intervention that you plan to do that's targeting that? I think with the viruses, you should know if they're there, and there are some antivirals you could try and see if they respond, even the ones that are less active, like acyclovir, famciclovir, valganciclovir, but sometimes they're helpful. With the flow panels, they would direct you towards therapies that try to restore immune function, and those aren't readily available. Those are more research than they are clinically available.
Thank you. Before we go to the next question, just a follow up on this one, Nancy. You are mentioning the dysregulation of the NK cells. There is a paper coming up in Natural Immunology from a German group from Li Yang, a consortium. My former PhD student is the first author, so I'm very proud, that found using single cell transcriptomics that the major defect in long COVID peripheral blood cells is related with mononuclear cells, so monocytes and so on. So do you think that this difference between NK cells do not seem to have a particular phenotype? Do you think that this may be due to the fact that there is a heterogeneity among the patients, or there is a hierarchy of defects among these different circulating blood subsets?
Well, yeah, I think there's considerable abnormalities in the cell type, and that the innate immune system seems to be more impacted than the adaptive. So the monocytes make sense. They also make an awful lot of inflammatory cytokines. So it makes sense that they could be important in the mediation of the illness. So I just think you're going to see more than one cell type being impacted. And for sure, we know that. There's a lot of studies to demonstrate that.
Thank you. Miguel Castelo Branco.
Okay, I will be very brief. So I do brain imaging, so my questions are focused on the talk of Michael. So we use at our center also neuroinflammation marker called PK, and we do some studies on neurodegenerative disorders. My first question is technical. You use the cerebellum, sorry for the rest of the audience, but it's really a technical question. You use as the reference region the cerebellum. My question is that in the cerebellum, you also have microglia. So this makes you would like to have a reference region without activated microglia. Maybe this is not my most important question, but I'm curious. I have another question that I think it's important more for the audience, but I would like, should I say already the second question? The second question is that you identify brain regions with increased inflammation sensitivity as an explanation to brain fog. So I have to be honest, I don't like the term brain fog. For a neuroscientist, it's a very foggy term. I would like to be a bit more objective, but this is just a comment, not to your talk in general. But so you mentioned the activation in the mid-anterior cingulate and in the vagus nerve. So, but I also saw other regions. For instance, imagine that you have activation of the locus coeruleus. The autonomic dysautonomia would be completely different. So, and this would explain why patients have so different symptoms when we talk about cognitive symptoms. So these are basically my questions, with a small third one, which is, what do you mean by inflammation sensitivity of a brain region? Is it just more increased microglia activation? And I'm done. Sorry for all these questions.
So the cerebellum normalized, we used SUVRs. We also did it with using occipital region as the normalization region and found similar. There's no brain region that lacks, these sorts of cells. So it is sort of a standard approach. We have A-line data that we'll also use from a subset of the patients. About a third of the patients with the ME group got arterial lines. So basically the question is, how do you know what to normalize to, basically? And so we have arterial line blood that we can also normalize to, and that'll be the next step. So yeah, brain fog is just sort of a colloquial term that people use, and it's technically cognitive control is what we measure. But the issue is that it's more than just cognitive control that people experience. So, let's see, your other question was about the specific brain regions.
Locus coeruleus.
Locus coeruleus, yeah. So the reason that I showed the figure, which was figure 5 in the paper that we wrote a couple of years ago in the long COVID paper, was to show the overlap of the nucleus of the solitary tract with some of the autonomic regions. And you're right, I mean, it's not just locus coeruleus, but the dorsal raphe would be right there as well. So, ventral tegmental and all that would be a little bit higher. But the issue is that when these regions get activated, the immune cells sort of pump out excitatory modulators that we think is going to just disrupt the sort of delicate signal to noise signaling that ought to be happening there. And so, yeah, there's going to be sort of cascading effects. It's challenging because there's going to be slight anatomical differences, especially in brainstem. So we don't really know that that's locus coeruleus, but yes, there's sort of activation all over there, more or less in patients, and that surely will be part of the reason that they're experiencing symptoms, I would think.
Thank you.
And before going here, I want to transmit another one from the audience online to Dr. Pretorius. Two questions, two parts. Do all long COVID patients display microclots, or are there subtypes of patients with and without microclots? And the second one is, any thoughts on what is driving persistent clotting in long COVID patients who improve on the anticoagulant therapy, but then deteriorate after the therapy is stopped?
Thank you. Those are very important questions. The first one, do all long COVID patients have microclots? Yes, they do. There's also microclots in healthy individuals. much lower levels, and they are also in diabetes, rheumatoid arthritis, and other diseases. What we are trying to figure out is the size of the numbers, how different they are, but we, in our experience, long COVID patients have much more than diabetes and other types of diseases, including ME/CFS. But the bigger question that we are trying to discuss and to unravel is what are the biochemical nature of these structures. So if you are healthy and you've got a few microclots, your body takes care of it, your immune system is working, you don't have so much cellular debris, so your seeding areas is much less. The problem with long COVID is your immune system is muted in some instances, that doesn't function as it should, debris is not removed sufficiently, prothrombotic areas are formed, all of the inflammatory molecules that are entrapped in it, nets are associated with it to stabilize it, to make it structurally stable, for breakdown, perhaps not so easy to break down, together with alpha-2 antiplasmin or similar molecules in circulation. So the question is rather, what is the biochemical nature of these structures compared to the number and the sizes? But in our minds, yes, long COVID's got much more. Now, the question of treatment, so some people have been using anticoagulation therapy, where when they are on the anticoagulation therapy, they become much better because of the fact that the body just reduces the clot formation, so you get much less microclots to form in the first place. Some people have also been using nattokinase, lumbrokinase, serrapeptase, that are enzymes that enzymatically break up these deposits. But there's some individuals who, if they go off these therapies, they relapse and they again form microclots. So my only explanation for that is that somewhere in the body there must be viral persistence, spewing out spike protein, forming new microclots that are structurally difficult to break down by the body itself, or by breaking up via the normal plasmin process, or then if the immune system is still muted, if there's spike protein in circulation, there will always be a trigger for prothrombotic little deposits to form. So I think that's the main issue. So my hope is in the near future, we will have some medication that will get rid of the viral persistence, get rid of the proteins that is in the first place the triggers of these abnormal clotting, and then together with clot busting medications or clot preventing medications, and obviously there's lots of dangers with anticoagulation, as we all know, so be very careful when we take it, but perhaps there's then a utility for those type to be added after this initial onslaught of viral persistence is removed from the body.
There's a question in the audience over there.
Here, I'm Giada Draos, president of the CFSME Italian Association, and I've been a patient for 35 years. I was severe for some 20 years, and now I'm more or less moderate and improving constantly. So my question is, are you doing or planning to do longitudinal studies, especially with those patients whose severity changes through time, to see the difference that can be there? Thank you.
So maybe I'll ask Nancy Klimas to answer this question.
So absolutely, longitudinal. One of the huge advantages of having an illness that started with a very clear bug that's so ME/CFS-like, that we're going to learn from long COVID, is that we do have these very large cohorts that are being followed from acute infection all the way through years now of follow-up. The Recovery Initiative at the NIH has 15,000 patients in a longitudinal study. That's no small number. And there are a lot of other studies that are following longitudinally. I will say from my own ME/CFS experience, and it sounds like yours as a patient, it changes over time. And one of the things we need to be aware of with our long COVID patients is that in ME/CFS, the most inflammatory time is the first 3 years. And then it shifts. It doesn't stop being inflammatory. It's slightly less inflammatory, but it gets more autoimmune, more autonomic, more other things going on with duration, which makes sense. So I think that the long COVID people that are clinicians can learn a lot from the ME/CFS clinicians who've been doing it for decades. And I also think that the ME/CFS community is looking forward to the investment of scientific dollars that's going into long COVID that might untangle much of what we really need to know to have effective therapy for ME/CFS.
Thank you. There is another question in the audience over there.
My name's Emily Kate Stevens. I'm a journalist, and I've actually had the privilege of talking to all three of the speakers, and I would just like to thank all three of you for your incredible work over the last, well, particularly for me, over the last 5 years. My question's for Mike. You talked about the increased energy requirement that you saw in the anterior mid-cingulate in your ME/CFS and long COVID patients. And I just wondered, do you think that requirement for additional energy in the brain is one of the things that is a driver in the huge fatigue that these patients are seeing? Is it the driver that way? We were talking yesterday about efferent and afferent. Or do you think it's all the other things, the autoantibodies, the vasculature problems, the muscular problems that are driving the problems with energy use in the brain?
Yeah, so, technically what that measurement is, the fMRI bold response, is just the flow of blood. Hemoglobin has iron in it, and so you can detect the movement of blood with strong magnets. And so all it's showing is that more blood was needed to mobilize to engage in that task. The brain uses a disproportionate amount of energy relative to the rest of the body. So I don't want to just assert that that's part of why people feel tired. I don't know that for sure, but it is the case that the brain uses a disproportionate amount of energy. I suspect that it's sort of everything else as well. If there's less perfusion, et cetera, all the other things that people have talked about over the last day and a half is probably adding up. Yeah, that would kind of be my way of thinking about it, yeah.
Thank you. Another question from the audience to Nancy Klimas. What are your thoughts on giving monoclonal antibodies to long COVID patients with very high antibodies to spike? And are there medicines helping patients with this type of hyperimmune response to early variants?
So Andrew Shaw has some beautiful data on people with high titer antibody and low titer antibody. And he shows that in long COVID, 75% of people with long COVID don't maintain their antibody response and have patchy holes of antibody coverage. But 25% aren't like that. Of that, I think 15% look pretty normal, but 10% are these hyper immune responders that have very high titers. And in that group, there are some people that are still missing, the variant that matters to them, that they might be a hole. But he perceives the hyperimmune people as the people that are getting vaccine injuries and that type of thing, that they have this very brisk immune response. The majority, though, is fitting in this group that haven't been able to maintain their humoral response to the variants they've been exposed to or the vaccines that they've been exposed to. So we will be doing work with his group with our biorepository when we get done with the study and we can unblind everything and all that. So we'll be able to see if we have responders that are predicted by the kind of baseline antibody patterns that they had and whether or not the monoclonal fills those holes. He does have a few patients that he's got longitudinal data where the monoclonal antibody therapies did fill the holes. So just, a handful of patients that he's seen as open label patients. So I think that's probably the right answer to that question. I mean, I will say this is an early study. Mike Pelusa did a study with a different monoclonal and a smaller N and did not get a clinical response that was a primary, he didn't meet his primary outcome variable. And that was disappointing last spring. But it was a small pilot, and this is a better powered study, and it is a different product. So perhaps we'll see something different. We'll see.
Okay, and the last question is from the audience here.
Resia, David Sistrom from Boston. Quick question about your 2-day CPET study. Did the development of either microclot number or size provoked by the first exercise bout influence the second exercise bout, VO2 max, anaerobic threshold, or the development of PEM, post-exertional malaise?
The CPET study was done at Markvar, his laboratory in University of Derby. So I don't think the microclots necessarily, well, we don't know if the microclots necessarily affected the VO max, or whether it's the microclots or just the how the patient reacted to the CPET. But what I can say about the study, it was also chosen, the participants were chosen not to have severe post-exertional malaise. They were on the, he didn't want to put very sick patients through this process. So I don't think his patients necessarily developed PEM after the CPET. But what we did find was that the bigger microclots broke down after CPET 1, but then they reformed, and then the process was changed. So we could see the bigger clots becoming less, but the less clots becoming more. So we think it's a reform and form process, and obviously that might influence post-exertional malaise, I'm sure, if you have got a sick enough individual.
So I just want to finish by thanking all the participants of this panel, and also all the audience here and online for this lively discussion. Thank you very much.